First of all, welcome back, everybody. The facilitators of this group, two of them you've met already, Drs. Rhonda Costa and Jonathan Tobin. Let me just introduce two new members who will be facilitating. First of all, Dr. Dana Ketcher, who's here with us. Dr. Ketcher is a senior research associate at the Memory Keepers Medical Discovery Team at the University of Minnesota Medical School in Duluth, Minnesota. Dr. Ketcher received her PhD in Applied Medical Anthropology and her MPH in Global Communicable Diseases from the University of South Florida. She completed an NIH-funded postdoctoral training program in behavioral oncology at the Moffitt Cancer Center in Tampa, Florida. Dr. Ketcher is presently working on the NIH NIA-funded project called Indigenous Cultural Understandings of Alzheimer's Disease and Related Dementias, Research and Engagement. And she provides support for the International Indigenous Dementia Research Network team. She also helps lead the research core at the Memory Keepers Medical Discovery Team through her expertise in qualitative research analyses in projects for both Indigenous and rural health. So thank you for coming, Dana. I first met Dana through some of her publications in community engaged research. Appreciate that. We also are really fortunate to have Anuradha Hashimi, Masters of Public Health, who works with Drs. Cost and Tobin as a community engagement specialist at the Rockefeller University Center for Clinical and Translational Research. So thank you for coming. And I'm going to hand it over to the facilitators now.
So I'm going to go ahead and just get started. We have a very packed schedule, so I'm going to really shorten what I was going to talk about so we can kind of get going. But like Dr. Pachter said, my name is Dana Ketcher. I'm currently I'm in Georgia right now, but I work at University of Minnesota in Duluth. It's beautiful up there. Come say hi if you're ever in the area. So I have kind of a wide range of community-based participatory research background. What I'm going to be talking about very shortly today and showing you Jamboard, which is what we're going to be using today for our breakout sessions, our sub-breakout sessions, is work that I did during my postdoc, working with basic and applied research scientists, but putting them in connection with patients and caregivers. So I worked at a cancer center. I worked at Moffitt Cancer Center, and I was brought on to an opportunity, which was really kind of a chance encounter. It was started by Dr. Eric Lau, who's a tumor biologist. So bench science, working just with cells and doing stuff I will never understand because I'm a social scientist and a medical anthropologist. But he studies melanoma. So he got put in contact with patient who was diagnosed fairly young with stage 4 aggressive melanoma. She wanted to learn more about the kind of research he was doing. So from this partnership really grew what we ended up calling the Patient Researcher Forum. And it was really a place for patients and their caregivers to come to Moffitt and tour labs that were doing research on their specific type of cancer. And then on the flip side, they would kind of do that tour of the lab, and then they would come into contact with all of the people working in the lab. And then we'd sit down and have a forum basically where the researchers who worked in the lab were able to ask their questions of the patients and caregivers and vice versa. So it really was this kind of bi-directional program where people could learn from each other. It was really a place, I think, for bench scientists, at the T0 kind of level of the spectrum, who don't necessarily always get a chance to talk to patients and caregivers. It was really a chance for them to interact and see kind of what the consequences of those drug therapies are that they're working on. They don't always have that kind of patient-centered focus. So not only that, but the patients and caregivers then also got to learn a ton about research, right? So they got this kind of peek behind the curtain of what goes into research. And so that's a very shortened version of what I was going to talk about, but I did just really want to quickly show you what we're going to be working on today. I was going to kind of walk you through my project on the Jamboard. Oops, sorry. But it looks like we are out of time. Are you seeing a Jamboard? Okay. So basically what we're going to be doing is when we break into I think we've settled on 2 groups. We'll be using Jamboard. If you've never used Jamboard, don't worry. It's pretty self-explanatory. But you're going to be focusing on a health need identified by a community member. If you need to edit things, you just double click it and you can write in here, whatever it is. We'll say diabetes. And then we're going to be walking you through priorities and partnerships along these different stages of the translational spectrum in the first section, and then you can navigate to the second one up here. And to add, so we're going to ask you to kind of think for these different stages, right? T0, T1, T2. About the different priorities and partnerships that could exist. And so we'll be adding just sticky notes. So if you go over here on the left-hand side, you can click a sticky note, make a note, and then you say save, and you can make that note move to wherever you need it. Okay, so that's just a really quick crash course on Jamboard. But I'm really excited to work with you all today, and I'm going to stop sharing and hand it over to Dr. Coast and Dr. Tobin to explain kind of a little bit more about what we're going to be doing.
Thank you. And thanks for introducing us to Jamboard. It looks like a very good way of approximating what we would be doing if we were all in the room together. So we're going to work through this exercise in two components. And what we're going to do is in a moment, we'll break into 2 work groups, and we'll ask when we go into those breakout rooms for the community partners to first identify themselves. And what we want to try to model here is what this process really looks like in trying to build full spectrum translational research teams. So we'll ask the community partners to indicate through those sticky notes what their single highest health need is in the communities where they're working. And then we'll ask the team to begin to think about what are those priorities specifically as related to research questions along the spectrum, and who are the partners that would be helpful in trying to develop these full spectrum teams. Then we'll get back the groups together after about 15 minutes. We'll do a quick check-in, ask each of the 2 groups to report on first half of the exercise, and then we'll go back into the breakouts and try to operationalize those needs, questions, and partnerships and priorities into aims and hypotheses. And most importantly, what are the definitions of success here? What are the outcomes that would be most important to think about and to be able to demonstrate? So this is really just meant to give you a taste of thinking along this continuum vertically and horizontally, and then we hope you will take this approach back when it helps you to identify gaps in your research questions and teams and replicate this in your own research. And then we'd certainly love to hear from you after the meeting as to whether this is a helpful exercise. Rhonda, other introductions to this?
We'll be asking each team to identify who will be the presenter and someone to be the scribe. And so if Jamboard intimidates you, maybe you're not the one to volunteer to be the scribe, but it does look pretty straightforward and easy. And I think that's it, just to sort of, be respectful. It can be very exciting, and let's make sure everyone has a chance to speak in the spirit of the way that we try to really conduct these. And this should be fun. I guess I do have one question. Dana, will the Jamboard link be in our breakout room, or do we share it? And how do we assure that the person who's the scribe can actually write on it?
Yeah, so you can just copy the link that I sent you and just put it in the chat and share it with people. It should, as long as they, most people should have access to it. It's editable to anyone who shares that link, but if you have a problem, just let me know and I can try resharing the link again.
So can we collaborate on it? Can multiple partners write on it at the same time?
Yep, anyone can write on it if they have that link.
Okay.
Great. So I guess now's the time that we're going to divide up into the 2 work groups. we had more people sign up, and I had 4 different groups with names and everything. But perhaps the easiest way would be just to, I'll look through my Hollywood squares and sign 1, 2, 1, 2, 1, 2 to people. We do want to have at least one community member in each of the 2 groups. And so I know that Gwen, as part of our community advisory committee, would be one of those community members in one group. Can some other member who is a community member raise their hand and identify themselves as being a member of a community, meaning non-institutional research member? Do we have anybody? And again, the only reason for this is that we would like our community members to identify the research topic that we'd be doing this exercise on. Okay. So I guess for the second group, you guys will come to some consensus as to what the research question will be. So as we're dividing into the groups, I'm just going to go through Claudine Jerkovitz, number 1, Nicole Roden, number 2, Gwen Anglet, number 1, David Edwards, number 2, Erin Nescott, number 1, Vicky, number 2, Martha Hall, number 1, Angela Sy, number 2, Karen Huff, number 1, Jean Warrington, number 2, Kim Williams, number 1, Rochelle, number 2, Dave Chen, number 1, Susan Burkhoff, number 2, Emma Daybranch, number 1, Alex M, number 2, and Dana Littleton, number 1. So Karen, how do we switch into these groups?
So now we have to go to the icon at the bottom that says breakout room. But before everybody does that, our breakout rooms were identified already as A and B, C, and so if you're number 1, you're an A. If you're a number 2, you're a B. Just so you know that. And Jeannie, I think I had you down to record. You won't need to record now because I'll be in that subgroup. And so I think we're okay. And Emily Marvel, you would stay in the main meeting. So everybody can just choose at the bottom that breakout room that looks like the little window. Click on that, and you're going to go to the subgroup A or subgroup B. Again, subgroup A are the number 1 group, and subgroup B would be for those that were identified as number 2s by Lee.
And then Anuradha and Rhonda, do you want to go to A, and then Jonathan and I'll go to B?
Sure.
Okay.
Sounds good.
We'll see you all.
I will just say this has been very helpful already. Just thinking through and pushing on those areas of the T0, T1, T2. I think so often feel compelled to be very focused on one particular bucket or area or intervention. And so having this broader view is extremely helpful.
It's interesting because it looks very simple, like how could this help? But it does. And even the observation, oh, it's going to be all the same people. Well, isn't that interesting?
We still only have 13 participants. Oh, here we go.
I wonder if they went back to the general group.
That's where we are.
That's
No,
what
this is the general group of this breakout. I mean, the general workshop afternoon thing.
I didn't think you could even get there. All right, well, I'm going to go nudge because we could be doing something else. We can't find them. They're not in the other room. All right, well, let's keep going then. Perhaps we'll wait for Karen to come back. But I think they get about 30 seconds and then maybe we keep going and convene at the end. So let's keep.
Can I send them an email?
David, you were making, I'm going to let the organizers do it. David, you were making some observations. Did you want to say more?
I think as I was saying before, it's easy for me to get kind of, as you noted, focused on the trees as compared to where that forest is. And to now thinking about it more broadly, a lot of people operating in different copses of trees and different areas, and then being able to say, well, actually, we would all benefit from a larger framework for understanding how that basic science is being done at T0, and if they can be connected with these groups of patients or advocacy groups or things like that earlier on, who often have much broader ideas as well as to what to engage with. And then rather than having that engagement occur all the way at the end when we're talking about dissemination of results, bringing that further up. And I think we talk about that often, but how that actually happens when we're thinking about very specific things and specific interventions, specific projects, specific outcomes, how to maintain that larger view, I think is challenging, yet also what I think people really want to do.
Right. So I think it's like this. So Dana, where are your people?
I am so confused what is happening right now.
Just stay here.
Yeah, it says that there are 13 people. We moved from our group into the CE across the translational spectrum group. But now for some reason they're in the subgroup B, like they're back there, but I just went in there and no one was there. I couldn't see anybody.
So we always only came to the translational spectrum. We all came back to that. We didn't seem to be anywhere else. We just came there.
Yeah, same. So I'm not really sure what's going on or if we have somebody that can work this on the back end, but
so we're just continuing our discussion. And
that's what we're doing too.
So can you find the rest of your group?
Yep, I can get in with my group. It's just, I don't know if we're ever going to be able to come back together.
So, I'm here. I made it.
Oh yeah, David. Okay.
And Emily made it too. Emily Marvell made it.
Yeah.
I'm very confused.
You just have to choose this one. I don't know what they choose previously.
Right. Well,
right. You don't leave the room. Maybe they left the room.
Oh, okay.
See, like at the bottom of the screen, mine says leave room. You don't do that. You go back and choose a different breakout room.
Gotcha. Okay. I will try and get them back in here.
So we're going to continue our discussion. Right. So, so David, yeah, just doing it deliberately just helps. And you can see, so we had a little bit of an awkward start. So what, right? I mean, we have to find our way, and you might move your tabs around. You know, they're not going to always be, it's not going to be articulated as a priority initially. It might be a method, and then you figure it out. All right, here they come. Welcome.
We're pulling everybody separately. They're coming. It's just taking a little longer.
So Karen, was it the case maybe that they click leave the room instead of?
Yes, they clicked out of yes, instead of joining a different room, they went back to the original meeting, but that's okay. We're having quite a interesting conversation.
So where's
so we have 21 now. So I'm just going to go back and make sure that
Jonathan though.
Right. He should be coming.
Funny.
He's the only one in that group. There's only one in group B.
There he is. Hi, Jonathan. Welcome back. All right. So do we have everyone?
Yes, there's only one person left there.
All right. Jonathan, did you want to lead the check-in?
So I would say our group did a great job at the distal end of translation. We were light on the early translation, but who from our group would like to present? I don't remember, Vicky or Erin, was one of the two of you going to present the summary of our Jamboard?
I can, and then other group members, if you'd like to jump in, feel free. Oh, this was looking a lot more organized when I was just in there, but I realized I overlapped a few. So as Jonathan noted, we did, can you hear me?
Yes.
Okay, yeah, I'm yellow. We did start on the T4 end. As I realized, as I stated the situation, we talked a lot about elevated blood levels in kids and kind of the regulatory side of that, and then worked backwards to think about who needed to be involved. So on the T4 side, we said that enforcement involves the housing, schools, EPA, DNREC, the environmental side. But then as we worked backwards, we looked at how are these regulations set? What kind of doctors are involved and scientists in figuring out like why that lead level, how it gets elevated, why it's so bad that it's elevated, and then kind of in that T1, T2, how this is recognized in kids, what we're seeing, and then why people are involved in the at the table, who has an investment in making sure that these lead levels don't get elevated, or that they are treated if they are elevated, and those kind of implications, and what that looks like for a parent versus for a school system. And for then we transition to priorities, and the underlying one being eliminating disparities, and making sure that we are recognizing that this is felt in different ways across the state, across the nation. I'm from Delaware. Sorry, I should have said that. We talked about Delaware, but we also talked about comparative states, and that health literacy really plays into it. And all of that has ramifications racially and ethnically, and definitely income-based as well. So I'm like really not watching the time. So I'm just going to hand back because I gave an overview. Did I miss any key things, or should we go on to the other group? Right.
You're muted, Jonathan. Yeah.
Mentioned the basic science question that we posed and the basic science partners that we thought were necessary here.
Yes. And that was kind of like a challenge point for us in figuring out, like getting to that T0, what kind of foundation. And I think that's some research that I want to do on my end.
So we did talk about the chemists who helped develop the assays, the investigators who developed the mouse models. Rhonda, I was remembering our colleague who talked about nose pokes and as a measure of cognitive ability of mice, and the reduction in nose pokes as a response to lead poisoning was part of her assay development. So I think we have some work to do in terms of understanding who the basic scientists are. But let's, Erin, just talk about the shared priorities here.
Sure, yes. So the first one being that elimination of disparities. That was the top priority, right? So thinking about who this is affecting, across the nation, what children may be at higher risk based on their environmental factors. And in the same vein, how are we communicating these regulations, which ties greatly in with health literacy? Because if we know that any scientific rule is communicated out and translated out, it has to be understandable at the patient level. And we're talking about very young population, so that trickles to the parent and the school setting. So considering those priorities is key. Was there one more, Jonathan?
I think that's good. Let's go, Rhonda, to your group now. Thank you, Erin.
So David Chen is going to synthesize for our group. And David, I don't know if you have the link or if Honorata.
Do you want me to share my screen? I have it up. Whatever.
That might be easiest. I do have it as well, but if you share it, that will be quicker, I think.
So David, I'll let you walk us through this.
Yeah. So
and I think your general remarks about the experience that you made before were also interesting, if you want to share those at the end.
Yes. So what we focused on was access to mental health care. And this is a very broad area. And I think naturally the conversation gravitated towards the T2 to T4 areas. And so we were talking about service models for delivery of care, screening, access in different environments. A really important point was equity and access and inclusion, and the voices of different stakeholders, including patients as well. And then as we were filling in these different priorities and partnerships, realizing that thinking through areas from T0 to T2 was important, but more vague and more ambiguous for us to come up with initially. So kind of taking that step back and looking at the process of how we came up with these priorities and partnerships here, we kind of recognize that it's, I know for myself at least, very easy to focus on specific trees or little clusters of trees, but being able to take a step back and look at the forest to say, there are a lot of overlapping groups of persons. For example, advocacy groups came up in a number of these partnership columns. Pharmacologists, geneticists were groups that we didn't think of initially, but were really important in kind of probing that upstream area, so to speak, from like T1 or T2. And then so I think a lot of what we were doing was trying to understand these different classifications, and then what does it look like to begin to synthesize those things together, and then having things move across those categories with the different partnerships. Is that a fair representation of what we talked about?
Anyone else from the team want to chime in? Well, I think the group did a great job at what was initially sort of, there was, silence facing the matrix. And then people warmed up and sort of began to see that you can do this. And I think obviously the difficulty populating the left end of the spectrum is we don't have those partners in the room, which is why you need those partners in the room to help you have that discussion together.
So think of the adage we heard this morning, no research about me without me. And it's clear that to make this work in building full spectrum translational research teams, it's incumbent on all of us to bring the partners to those meetings, to bring the basic scientists into the discussion, and also to bring the policymakers, the regulatory, those who have regulatory responsibilities, because we depended heavily on both of them in our discussions, but we were speaking on their behalf. So I think that same principle applies there.
Yeah, I think that this might be my cue to chime in a little bit here. As a community member, within this conversation, quite honestly, I found the process very confusing. And I think that I would have benefited from a little more explanation about the spectrum and what you'd be looking for in the process before actually jumping into the process and trying to operate the process. So all that to say that, having the various stakeholders, community members, in the room with you means that you need to help them not only give input in terms of the questions, but help them understand the process first and then go into that so they can more fully participate. Because I didn't really feel like I could participate that well.
Sorry, you felt that way. Go ahead. We're going to have another round at it. Realize, of course, this process usually doesn't take place in 45 minutes.
Yeah.
It takes place over a series of meetings, over a series of days and weeks and months, that we don't try to get all of this articulated in 45 minutes because it requires reflection. And I agree with you, a sort of understanding of what can happen in each phase. And we do that by sharing examples and, suggesting possibilities. Jonathan, do you want to comment a bit more on the process?
I think of this as speed dating. And so part of it is really building the relationships. And this was just an attempt to encapsulate what that process might look like. I think one of the disadvantages, one is it's the short amount of time, and two, we had very limited representation in our two divided groups. And I think if we had a more broad representation, Lee, this is, I think, a reminder that an activity like this would benefit from maybe some specific invitations, bringing in a basic scientist to each of the rooms, bringing in a policy or regulatory decision maker, et cetera, so that we're not speculating. Because this really left it up to us to think what would be important to them. And so, Gwen, I hear what you're saying, and again, this is just a limitation of how tabletop exercises can work, but it's really meant to show that this is a process that unfolds and can unfold over a much longer period of time. But the key issue is having the right people around the table, and also recognizing not everybody can be there at the first meeting. So having a process in place that catches people up so that every time you have a meeting, is a way of bringing new people in. We had some turnover among the clinicians, some turnover among the laboratory investigators in our experience. Interestingly, the patient participants who were part of the research team had 100% retention across that process, which I think was very gratifying to them, to us. But recognizing that turnover is intrinsic to all the work that we do. So we need a way to bring people in and bring people up to speed so that they feel comfortable contributing and participating.
Thank you.
So at the risk of making people feel even less ready to take on the next part of the exercise, in the next part of the exercise, we were going to try to focus on aims and hypotheses, measures and outcomes. So recognizing that we don't have basic science representation in the two rooms, I think we should just stick to the T3, T4 cells of this, and then use this again to go back and say, well, who are the basic scientists that we might need to reach out to? And similarly, who are the partners on the implementation and sustainability side? Who are the community organizations, the advocacy groups that really need to be part of this process? So this, again, is that iterative process that we need to put into place so that as we identify those needs, we are able to continue to bring new partners into this. So are we ready to go back and do the second half of the exercise?
So how should we manage our time?
That's what I was gonna ask.
Technically, we have 20 minutes. So if we're going to have time for discussion, how should we do this?
Well, another option is to not separate and maybe to work through these two exercises jointly.
Why don't we
That's
do
what I was
that?
gonna suggest,
I think that would be fun. Jonathan, why don't you lead?
Okay, so let's start with the mental health question, since I need to, as a new partner to this, need to quickly come up to speed. So I have some sense of it, but what would be the initial hypothesis that brought your team together?
Can you share the screen, Anurata?
So David,
So we didn't articulate a hypothesis. We articulated priorities.
so what would be the hypothesis that underlies or derives from that priority? How to improve access to mental health care. So to me, there's an underlying assumption that access is limited. So how would you articulate that in terms of an aim or a hypothesis?
One possible hypothesis is that access may be limited due to stigma regarding mental health, which brings specific barriers to access to care and appropriateness of care. So, we have to bring in the whole stigma issue, which I believe can fit at least T1 to T4.
Okay, so let's stay with stigma for a moment. So let's locate that on the spectrum. I'm not sure where it fits into T1. I could see it closer to T2 or T3, perhaps.
Well, I'll give you an example for T1. While we as clinicians and researchers may see the goals of individual medicine as really providing the proper therapy to each individual, there could be the potential of concerns of differential treatments for different groups, for example, race, ethnicity, et cetera. So that I think there's just a potential for misinterpretation of what individualized medicine is and how that might contribute to, I see it as decreasing disparities, but taken from the perspective of a marginalized group who's always had difficulties with medical research, they might see that as increasing disparities because we're giving different therapies to different types of people.
So you're looking at the heterogeneity of treatment effects as a way of trying to personalize treatment and to understand the underlying mechanisms. So let's stay with the mechanisms, try to come up with an aim that might get at those different mechanisms that might mean that an intervention could work differently across different populations. How would you turn that into a testable hypothesis?
We need help with that one.
So let's just assume, not being a geneticist, someone's cringing somewhere. Let's assume that there's an allele or a gene or a area of interest where the hypothesis is that there's some set of variants that might be associated with a better response to a particular treatment as opposed to a poorer response to that treatment. So what would be interrogated there would be some genetic profiling to see if that holds up. If you look at groups that have differential treatment responses, that's supported by some genotype that reflects that therapeutic phenotype.
So could the aims then be identify the different genotypes that lead to different treatments? Or that
at a very high level it is. That's probably too exploratory to actually operationalize into a specific experiment, but yes, that's the general idea.
So Lee, let me try a different example that came out of our research where we randomized women to a group behavioral intervention, HIV positive women to a group cognitive behavioral intervention. And we conducted it based on the feedback of our community participants that we really needed to target 3 different communities: the English speaking, the Spanish speaking, and the Haitian Creole speaking population. So we recruited interventionists who were bilingual in any 2 of those. We found some very significant heterogeneity. The English speaking women benefited from the group behavioral intervention. The Spanish speaking women benefited. The Haitian Creole speaking women were actually harmed by the group behavioral intervention. And when we went back and tried to understand it, it was exactly the concept of stigma and the stigmatization of being HIV positive that made the Haitian Creole speaking women very uncomfortable to be in a group that was a group of HIV positive individuals. So there's both a cultural component, linguistic and cultural component here to that heterogeneity, but also a stigma and anthropologic component. So how would we try to investigate that more deeply? What would be our measures of success in an intervention like this?
Increasing the communication of the people, the women that were speaking Creole, increasing their participation.
Okay. So again, this gets back to representation and participation.
This is a deliverable, right? Or an aim?
Measure.
Yeah, so this would be.
Well, actually, I'm not sure, Jonathan, where you intended it to be.
I'm not sure I understand what's the intervention here. Did we define the intervention?
Lee, we'll go back to you on that. What was the intervention you were thinking about that would directly address stigma?
Well, I may not have thought of it as a specific intervention, but a specific hypothesis. And the hypothesis being that any intervention for a mental behavioral health issue, we need to assess differential uptake due to multiple different identities people have or multiple different demographics. Does that make sense?
Yeah, so are you kind of like, you are thinking like of implicit bias of providers and how that impacts how treatments are given?
Well, yeah, I think we could create hypotheses on both the provider side as well as the recipient side.
Right.
But-
So
but yes.
I thought I heard you saying that the expectation, that perhaps the expectation of implicit bias or the fear of implicit bias made some populations less receptive to treatment.
Yes.
So there are a lot of, I mean, there are a lot of hypotheses to test there. The reason we're struggling with this is there's a lot packed into this. The cultural piece, the perception, the intention, the therapeutic outcome.
Right.
So
Did we decide where on the spectrum we thought this would fit?
Yeah, I would think this is a cross-cutting issue that you probably could apply to all different levels and or to research, questions at all different levels.
So it depends on how you interrogate the question, right? Whether you're doing it with I can't think of a T1 approach, but whether you're interrogating it behaviorally or some other way, whether you're doing an intervention or being observational. I'm not familiar enough with this, with interrogating this kind of question to tell you how to suggest how to design a proof of concept, what you would call T1, because I'm a very biological T1er. So.
Well, I can think of, just thinking of assumptions. I think we have this kind of cultural assumption that like science is objective and free from our own biases, right? So in the development, you see that kind of like even with mouse models where they were only using male mouse or mice, right? And they weren't including female mice to see kind of what in that kind of animal model T0. So just assumptions, I guess we also have about race. And that's obviously not being applied to mice, but that is apparent in every single stage of the translational spectrum, right? So that introspection by scientists at each level of like how their assumptions about race, gender, language, ability, like any of those things affects. That doesn't really help either, but I'm just trying to think of like T0 stuff, and that's an example I can think of.
I'm not sure if this fits into this, but also as a clinician, what I find is that we have a lot of resistance because of cost. Since a patient has to pay a copay every time they see a clinician for mental health, they're reticent, and so even if they had the greatest insurance in the world, they still have to do the copay. So I'm not sure where that fits in any of this, but.
Well, I think that's one of the barriers. And so it sounded like the original question about differential access to care depended on first identifying what the barriers are and whether the barriers are experienced differentially by different members of the population. Then there are potential interactions of stigma plus those barriers, stigma itself being a barrier, but this becoming a way that additional barriers become magnified, and the cost barrier may be different based on the income or assets that you have, or the insurance status that you have, or the access to mental health specialists in your community. So all of those become measures that can be assessed. I think the definition of the measure of success here is to improve access to mental health care and to improve or to reduce adverse mental health outcomes, depression, anxiety, substance use, etc., in the populations that are being served. So that's a much more distal outcome, but I would argue it's probably the most important one we should be thinking about, because that's in the end going to determine whether all of this was worthwhile. So this is hard stuff. This is not easy, and I think the gaps and the pauses here are just a reminder that, again, we need a broader representation of collaborators in these discussions, because they would help us more, I think, explicitly articulate that. But Dana, let me go back to one of the points that you were making, that there are all of these implicit assumptions baked into the studies that don't necessarily are not apparently obvious to the participants, but will directly affect the conclusions and the generalizability. So what are some of the strategies that become really important to guarding against those implicit biases and improving collaboration and participation?
Yeah, I mean, as an anthropologist, I think you're always trained to question your own biases, right? And we always write about positionality, right? So my position as a well-educated white woman, like how does that affect how people perceive me, who will talk to me, who will not talk to me? That is something we always consider when doing our research, right? And I don't think that kind of thinking through your identity is always something that's taught in other disciplines, especially when you kind of go up the translational spectrum, because they're like, well, I'm not talking to people, so why would that matter? And so I think for me, it's really about reflexivity. It's really about questioning all the time, like, what are my assumptions about a group of people? Because we all hold assumptions about people. It's, we're raised in a patriarchal white supremacist society. So we all have a lot of isms that we need to work against constantly. Even as someone that's, I study these all the time, it's still things that will come into my thought processes where I'm like, whoa, okay, let's like question that, right? So really reflexivity and thinking about how your identities, whatever those are, both the ones that people can see and the ones that people can't, how that affects the research that you do, and how that affects your interpretation of the research. And I think polyvocality is really important in that, right? So we're talking about including a lot of different voices within this process. So making sure you're not the only one speaking on behalf of a group of people, or that you're, what you're hearing, you reflect back to community members to say, is this right or not, right? And that's something that I do in my current work with Indigenous populations in both North America and in Minnesota and Ontario, is, we're constantly giving back our results and saying, this is how we're interpreting this. Does this ring true for you? And it's about data sovereignty, and they get to make decisions on what sees the light of day and what doesn't. So that's kind of, I think that's really important, is just reflexivity on your own stance, especially in the scientific process, which again, I think our culture assumes is kind of free from bias and judgment, and it's objective and all these other things. But we're all trained into a cultural way of thinking about things.
So does the team give you feedback, Dana, the other way? I mean, do they sometimes, I don't want to use the phrase call you out, but something like that? Do they inform you and just kind of call it out if they feel like you're biased or not looking at it the same way?
Yeah, absolutely. I mean, and that's part of the process. I don't take anything. If somebody said earlier, everyone has to be at the table as a learner, right? And I really take that to heart, that I certainly don't know everything about, the Native American experience of people who are caring for loved ones with dementia. So I need to come with all I can do is interpret the interviews that I'm qualitatively analyzing and bring it back to them. And, I haven't really had any call outs, I guess, quite yet, but it's been more like it's been more providing context or ways for me to understand it better within kind of like, oh, well, this is what they mean when they say this, like, you know, things like that. So I'm sure it'll happen, you know, like, and I'm excited for that day because that's a learning opportunity for sure.
Yeah. Well, so much of this is very eye-opening to me, and I really appreciate, yes, you know, you're hearing pauses from all of us, but that doesn't mean that I'm not engaged or intrigued. I'm just thinking, I'm processing a lot of this because it's foreign to me. It really, it's foreign to think through the whole process. It's foreign to, it's enlightening to hear what Dana just said about constant, even though you're trained, constantly questioning yourself, because I probably don't do that. I mean, I probably rarely do it. I think I kind of read back with my team and the people I interact with and my collaborators and that, but really doing true community engaged research, it's going to be a different, it's that is where my inherent biases or whatever my cultural norms are going to be, you know, questioned or exposed. And I'm saying that in a nice way. I don't mean exposed like I'm going to feel horrible. I'm just going to use it as a learning opportunity, but interesting.
Yeah, Erin, do you have a question? I think we're running up at the end of time. So no, go ahead.
It was just a quick comment. I was just going to say, I think collaboration such as this helps us to see where we can create spaces in our current research to up the ante in that community engagement and like find those niche areas that could benefit very highly from increased engagement. And we really owe it to our populations that we're working with. So thank you for the opportunity.
And education is one of those currencies. So I was asked that question earlier this morning about waiting for the results of studies, and we have to wait a long period of time for that, but we don't have to wait to learn from each other. And as I mentioned, when we brought the team together to study skin and soft tissue infections in that first iteration, we would have a clinician present a case history of a patient that they saw. And at the same time, we'd have one of the laboratory investigators presenting the results of a publication so that we were learning together, learning from each other. And that was a forum to ask questions that might be outside each of our individual area of expertise, but created, I think, an ongoing dialogue that was extremely valuable, that in the end helped us focus on recurrence as the unifying priority that was shared by every member of the team, and that was amenable to the second study and hopefully the next study that we do. So I think this has just been a rich experience hearing from both groups and recognizing that this is not easy. It's a struggle. It doesn't happen in 90 minutes. It takes time, but it begins with that first step, which is that conversation. Here's what I'm interested in. What are you interested in? Where are the areas of commonality? Where are the areas of divergence? And how do we build a functioning process and a team that we could work together, learn from each other, and continue to open up ourselves to new partnerships?
David, do you have a comment?
Yeah, quick question. So in trying to formulate this, it feels like a lot of this is very investigator driven, particularly on the research investigator, usually someone that's backed by an institution, a group, some kind of resourcing. And yet it's also polling kind of across the spectrum, what are the needs that are identified? How have different experts here, different groups approached the situations where a compelling need or gap is identified, but there isn't that kind of cohesion around the resources, the interests, things along the spectrum to be able to address it, yet it's still important, and being able to kind of reserve or carve out that space to recognize that importance, to be able to return to it when there are resources, or to be able to direct resources in that way. I don't know if that makes sense as a question.
I think it's a great question, and I think it really comes down to strategy that not every grant can answer every question. Some of this is building a portfolio of grants, and some of it means taking turns. So if there happens to be an RFA that's specific to the comparative effectiveness or population health question, the reciprocity would suggest, okay, let's focus on that. We'll try to build those resources in a way that keeps the team together, keeps the program funded, but it may focus on the T3 or T4. And similarly, my hope would be that the basic science investigators would come and bring an RFA that's relevant to their work, but recognizing that it isn't just about collecting the specimens, it involves building that team over time. Rhonda, did you want to add to that?
Yeah, there's something I want to bring up. I don't feel completely qualified to discuss this topic, but the pandemic and the development of the mRNA vaccines is this sort of incredibly hopeful but messy example of both engagement and lack of engagement. So the mRNA technology had probably been in development for a decade or more and had been, tried in some cancer environments. And then suddenly we had this incredible rapid translation from this probably T1 living technology to T3, T4 sort of instantly. Yeah. And in some of the ways that communities were left behind was because there was a lack of anticipation of this possibility and a lack of engagement of all the different entities that would be needed to understand not just delivery, but dissemination, implementation, vaccine, quote, hesitancy, poor communication from the scientific community, confusing communication from the people in scientific community. So it's kind of this perfect storm of both effective and ineffective full spectrum translation.
I am so glad you brought that up, because that's been top of mind for me almost during this entire pandemic. And I have struggled with my friends and colleagues to, they're hungry for information, and we just didn't do, like you said, we moved too quickly, we weren't ready. And I gave them information, but and then all the information on COVID that was a benefit that was freely accessible. You could get any paper on any publication on COVID, which is remarkable. I thought it was fantastic. But then the downstream effects of that is who's going to give the summary of that, or who's going to explain it from a lay person perspective to the public or to the community that really wants to know, that is dying to have their questions answered, and nobody's answering them.
And media was not the best translator of that science.
Say that again.
I said the media was not the best sort of honest broker of that information.
No. And that's what happened to us. Media, social media, and it quickly got taken out of our hands, I guess. And but I think we can learn from that. And I'm so glad you brought that up as an ending, because I really feel that there's many, many lessons to be learned from COVID, and positive ones. And even today, this breakout session was really helpful to me, because I think it helped me understand where some of those gaps occurred. I mean, I could get some of them, but not, I just didn't understand how something so exciting and so, empowering for many could just fall apart, that had so many other things that were not right about it.
And let's think about what a full spectrum team might have looked like if the basic scientists were working in settings that said, the cold chain requirements are not only going to be difficult in the United States, but they're going to be impossible in large parts of the world. So we need to work on either a way to deliver that or an alternative to cold chain, number one. And number two, while we were all waiting for those vaccines, for that pipeline of effectiveness studies to come out, we didn't start the process on the community engagement side of education and the importance of vaccine uptake, because by the time the vaccines came out, there was already so much counter propaganda about the harms of those vaccines that wasn't based on the evidence, it was based on conspiracy. And so I think this was a failure of full spectrum translational research to be intentional about what do we need to do to empower the basic scientists to accelerate that pipeline for discovery was nothing short of a miracle. But that pipeline for delivery has really been a failure, particularly in certain communities.
I want to be respectful of everybody's time because we're going over. So I just want to make sure that whoever needs to leave, feel free to. I would like to kind of start ending things up. David, Dave, you have your hand up.
Yeah, it's not a big deal. No worries.
No, go for it.
Yeah, go for it.
I guess related to the discussion is, oftentimes our T0, T1 investigators come to the table with their question ready that they want to answer. So how do you get them to engage, right? And it probably would have helped with this pandemic question as well. How do you get them to engage, other community members, I guess? Is there any experience there?
Well, it's really bit by bit. As I said this morning, it's sort of, one thing is to be led by peers. So something we did a few years ago is we took some of our successful laboratory scientists who had translated, and we interviewed them, and we excerpted that into 2 or 3 minutes about how community engagement informed their science. Because we had a researcher who works on DNA replication error repair, but she works with the Fanconi anemia population, which is a genetic disease that is its foundation is errors in DNA. So there are many, many mutations, many early cancers. And she was very eloquent about how the population was integral to advancing her research. And that once a particular problem was solved, like aplastic anemia with bone marrow transplant, nobody knew what was going to happen next because no one had lived beyond, the age of late teenage years. And so then it was only from the population that they could learn what the important questions were. And the important questions had underlying biology. So it's a long answer, but just by having someone like her talk about how the community priorities and needs can actually change the research question is powerful because they do listen to their peers. And we have other examples of investigators who are able to they can't always articulate it, but some who articulate very well how it opened their eyes and changed their science. Well, what happened to Jonathan? I think he was on the phone. So,
well, I think what we're talking about here, we're Dana, you're an anthropologist, you know about culture, but this is truly a culture change within research, within the culture of research. And I think we have a great start. It's going to take a while. It's going to, sort of diffuse down to the earlier translational levels slower and slower. But I think a conference like this really helps jumpstart that. So I want to thank everybody for participating. I want to thank our speakers and facilitators. My hope is that, as we log off, this isn't the end. If people have questions, we have everybody's email address. Feel free to email the conference organizers, and we'll make sure that the communications get out. But thank you, everybody.
Thank you, Lee. I learned so much.
So much.
Thanks, everybody.
Thank you, everyone.
pleasure.